All right, good morning and welcome, particularly to the four of you that are in here who have been just greeted by the speaker this morning, Dr. Liz Ackley. If you're in the Tanglewood facility or in the vicinity, come on down. We got a little breakfast going on this morning. This morning we have Dr. Liz Ackley, and I'm going to have to read because there's a lot of accolades on here about her bio that I thought that to me were really touching. And in keeping with what this talk is going to be about in our community, and really in keeping with I'll shut up so we get you to talk. The Carilion mission, I'm really meeting the needs of the communities we serve. Dr. Liz Ackley is a professor of health and exercise science and the director of the Center for Community Health Innovation at Roanoke College here in the Valley. In addition to being a passionate educator, Liz serves as the managing director of the Roanoke Valley Community Healthy Living Index, a citywide health surveillance system conducted in partnership with Roanoke City Public Schools to explore complex relationships between resident health outcomes and neighborhood-level infrastructure supporting healthy living. She also serves as project lead for Roanoke City's Invest Health Initiative and the Northwest Food Access Initiative. Her work has generated more than $13 million in grant funds and technical assistance to advance equity-focused community development projects across Roanoke's diverse city neighborhoods. For her dedication to teaching excellence and community advocacy, she's been honored with the United Way's 2024 Health Heroes Award and 2022 Outstanding Faculty Award from the State Council of Higher Education of Virginia, and the 2015 Rising Star Award for Excellence in Undergraduate Teaching from the Virginia Foundation of Independent Colleges. In her spare time, whatever that is based on that, Liz is an avid gardener, competitive trail runner, and triathlete. And one question is, living in the Valley, as an avid gardener, is your triathlete and competitive running to chase the deer away from your garden?
Oh, it is right now. Oh my gosh, yes.
With that, please welcome Dr. Liz Ackley, and look forward to the talk.
Thank you. Okay, I know this is probably a really different angle for you, and I'm kind of curious to see how well you already understand some of the information that I'm going to share with you, but I'd mentioned, or it was just mentioned, I'm a health and exercise scientist, and so I'm sort of coming into this space as an exercise physiologist. My previous work was with the blind community, and so my background, my PhD research was basically in how to prescribe exercise as a medicine to prevent, treat, and cure diseases in individuals who really have challenges with the built environment. And so as an exercise scientist trying to prescribe health-producing levels of physical activity, that built environmental pickle is a really interesting thing to try to figure out. And when I moved to Roanoke, I sort of decided, how do you advance that at scale? So I'm going to start my talk today sort of centering on that, but then my talk today is really an invitation to you to kind of figure out how can you take your expertise in the way that you think to help us continue to build health equity producing infrastructure in the Roanoke Valley. I'm going to refer to the Community Healthy Living Index quite a bit in this presentation. If you'd like to, that QR code that's on the screen here will actually take you to those research reports. So if you want to take a look at the data, you can do that there. Okay, let's first get acquainted with the goals of today, if I can get this clicker to work. We have 4 objectives because I know that you actually need to learn something, so I was trying to be thoughtful in what might be important to you as I put this presentation together. I'm going to get you acquainted with the Roanoke Valley Community Healthy Living Index in just a bit, and the goal here is to really help you quantify and reflect on the root causes of health disparities in the children that grow up here in Roanoke City. My second objective for you is to start beginning to explore associations between those health outcomes and family access to resources that are supportive of the vital conditions framework. If you're not familiar with that, we'll go through that. I'm assuming you kind of are, but I'll make sure we're on the same page there. My third objective for you is to realize that there are opportunities for you personally to engage in the advancement of health equity producing community development initiatives in our community, and I'll give you some examples of what that could look like right now and in the future. And then lastly, I'm actually going to invite you to recommend some points of intersection for this work to figure out how pediatricians and partners in other health sectors can really come together to support community health initiatives. So I'll give you really concrete examples of what that looks like here in just a second. But just to ground what we're doing because of who you are, as medical practitioners and who I am as an exercise physiologist, one of the things that I have found the more I engage in community development is that our way of thinking is lacking in some respects. We have been trained to think in terms of systems, and so that makes us really good candidates to support community development initiatives. So I mentioned I'm an exercise physiologist. When I'm working with a client, my job is to try to figure out how to apply a specific dose of exercise, so varying in intensity, in duration, or modality, to cause an intentional cascade of events across that individual's endocrine and metabolic systems, their neuromuscular systems, sort of the entire systemic response. I'm less interested in how a single organ system is going to function, because we know to prevent disease, to treat disease, and to cure disease, even if it's something like diabetes, where there's definitely a pancreatic influence, there's a cascade of events happening across the entire physiological system. Being able to think that way is incredibly important when we're trying to reduce or mitigate health disparities at scale. And so I think we have been trained in system science to allow us to move away from our siloed thinking to really think of this connection across systems, and in the community that helps us link policy, systems change, and environmental change strategies. So I'm going to begin with sort of grounding us in that conversation, because I think you are also uniquely positioned to do this work. I mentioned I work with a community of individuals with visual impairments and blindness. I did this throughout my PhD, and I really loved my work. I developed a community-level physical activity intervention that really helped to reduce the incidence of diabetes in the city of Nashville. And when I moved to Roanoke, I was super passionate about this work, but that special population just is not as prevalent in the city of Roanoke. And I found that for me, while it was incredibly rewarding to support an individual's ability to lead a healthy lifestyle, it wasn't enough. And so when I moved to Roanoke and looked at our infrastructure and how our infrastructure, very visibly, you can see it as you're driving around, creates opportunities where people have access to things in some neighborhoods and don't have access to things in other neighborhoods. And this felt like the perfect city to take the thing that I love and to advance it at scale. And so since 2010, I've been thinking about how do I use my systems thinking background to try to mitigate health disparities at scale. So I've been much more population focused. So I've been doing some work since 2011 here in Roanoke, but it wasn't until 2018 that I established the Center for Community Health Innovation at Roanoke College. As you may know, Roanoke College is an undergraduate-only institution. The goal of this center is to really position our students as agents of change in the community, and so I'm going to give you some examples of what that looks like. But my aim was to establish a translational research center with the primary aim of positioning citizens as decision makers. We serve as a neutral community anchor now that convenes residents and partners from traditionally disparate sectors together to try to figure out strategies to advance health equity. All of our strategies are data-driven. They begin with resident voices to leverage those voices, and then we position different partners in order to help us actually implement those strategies. I spend a lot of time providing technical assistance for cross-sector partners, most recently as diverse as stormwater, city planning, Blue Ridge Literacy, Goodwill Industries of the Valley. And so these are generally partners that are not traditionally in the health space, but we know that everything that they do influences health. So it's really fun for me to be able to continuously learn about how these different partners can support the advancement of health equity here in Roanoke. So let's dive into some data, shall we? Who doesn't want data at 7:30 in the morning? So just to re-ground us with your learning objectives, I'm about to show you some health surveillance findings so that we can better understand and quantify health disparities in Roanoke City youth. So this is data that you are probably way more familiar with, but I want to start at the other end of the life continuum in case you're not aware of this. In the city of Roanoke, we experience 14-year gaps in life expectancy in neighborhoods that are less than 2 miles apart. Do you know this? Oh, well, is that as shocking to you as it was to me the first time I heard this? 14-year gaps in life expectancy in neighborhoods that are less than 2 miles apart. That boggles the mind. And as health practitioners, we understand that there are myriad, factors that influence I'm not going to use the pointer, you told me not to use the pointer, that influence health over the lifespan. And we've been referring to these things as social determinants for a long time, and now we're starting to move away from that language because we know factors are not necessarily determinants, but they are things that influence, and so we're moving to that vital conditions framework. But we know over the course of the lifespan, things like experiences in childhood, including trauma and including positive experiences, definitely impact our health. Our health behaviors are really grounded for us in children, right? We know that social support systems, our education, our parents' education, family income, all of these factors are factors that contribute to whether or not we have disease and functional impairment as we are getting older, and what our life expectancy will be. But that doesn't give us an opportunity to prevent things, right? So in 2010, I stumbled on a tool called the Community Healthy Living Index. This tool was actually a survey that was designed by the Centers for Disease Control to be implemented through YMCAs to better understand how communities were supporting children. I'm like, oh, I really like this idea because it puts a really neutral partner. No one's afraid of the YMCA. No one thinks that's a powerful entity, right? And so they're not going to coerce anybody when they're trying to gather data. How do we position the YMCA to help people at large better understand contexts in neighborhood environments that could contribute to health disparities? And so I adapted that in partnership with Roanoke City Public School Systems. We disseminate surveys to every family, pre-K through 5, and we ask them a bunch of questions about neighborhood environments and school environments. And those questions really key on the level of access that families have to health supporting resources, like things that promote physical activity, things that promote healthy eating, things that promote a good social culture in a neighborhood. And then the other thing we do is we gather weight-related health status from every child in the school system. And you can see this is data from 2018. 79% of all students in Roanoke City Public Schools are represented on this slide. That is huge from a health surveillance perspective for an entire city. And then what you're seeing here, this is just a very basic hotspot analysis. This is not an area of expertise that I have. I took the GIS course with my undergraduates 1 year to learn how to make really rudimentary maps like this. But instantly we can see place-based disparities in childhood weight status. So the red map here is showing overweight and obesity in children. Again, this is pre-K through grade 5. The darker the color, the higher the prevalence of childhood obesity. And I believe in this figure, the darkest red is indicating school zones where the childhood overweight and obesity prevalence is over 54%. So again, this is elementary school. And if you're not crying right now, then I don't know what's wrong with you. 54% in children in elementary school. That is showing a drastic need. And you can see from the healthy weight map there in the middle and the underweight map there sort of towards the end that this suggests that there are some place-based disparities. Most of the obesity is in the northwest and northeast of Roanoke there. So we've been collecting this data. We started at Hurt Park and Fallon Park Elementary. So we went to our medically underserved areas first to try to just really help individual schools. We had such good luck at those schools implementing garden curricula, putting in infrastructure to support just better nutritional eating, that in 2017, Roanoke City Schools allowed us to go citywide for the first time. And so we have moved away from an annual data collection surveillance system to now one that is working in 3-year cycles. So I'm actively collecting data. So actually, if any of you have children in elementary school, you received a survey probably in the last 2 weeks asking for data. So send it to me, please. This allows us to track childhood outcomes in weight-related health risk over time. You can see from 2019 to 2021, we were able to capture what COVID did from a weight-related health risk perspective. But generally speaking, this data allows us to understand that childhood obesity and overweight in Roanoke is considerably higher than state prevalence rates and exorbitantly higher, than national rates. The ability to track that data over time is also helpful for us when we are mining down to different demographic populations. And so I'm really interested in looking at temporal trends by grade, by basically child age. so we can get a better sense of when is it best to intervene so that we can prevent chronic diseases from happening, so we can prevent childhood obesity from happening. And this data is showing obesity and overweight rates by grade level each year. And after COVID, it became just alarmingly obvious to us that if we weren't intervening before kindergarten, it was already too late. So this helps me kind of think about where should we put our resources as a community. Early childhood education, early childhood health-related programming is going to be really, really important. And those are things you probably already know, just based on what you guys do. We gather this information, and families also give us their home address. So this allows us, using GIS, to mine not only health-related weight status, but also perceptions of neighborhood environments to the individual's home. That gives us really granular information to start looking at census tracts and the relationship between place and health. So I'm going to start sort of laying the groundwork for that story. This was the first descriptive study my undergraduates did, was just overlaying childhood obesity rates with life expectancy in our city to see, hey, are those data points telling us the same thing at two ends of the life continuum? Really early childhood, and then with life expectancy, end of life. And visually, so again, not statistically, we did see some patterns here, that in the neighborhoods with the lowest life expectancy, childhood obesity rates were high. And in the neighborhood with the highest life expectancy, in the census tract that we're actually sitting in, childhood obesity rates match the national prevalence rate of 17%, and we experienced the highest life expectancy. And so this was the first metric that allowed the city of Roanoke to look for place-based, neighborhood-based disparities in health. Because this data was actually collected before community health assessments were mandated by the federal government. So this gave us the first understanding of actual health disparities in the city of Roanoke and connecting it across the life continuum. My favorite part, however, is because of those surveys and because we can mine what those families are saying to their residential address, it allows us to understand barriers to healthy living that families are experiencing at home. And so what this figure is demonstrating is perceptions of neighborhood safety for engaging in physical activity during the day. And you can see in the neighborhood with the lowest life expectancy, only 57% of those families believe that their neighborhood is safe enough for them to engage in physical activity outside during the day. 57%. And then in the census tract where we are sitting right now, that was a neighborhood that had very high perceptions of neighborhood safety. So 83% of families perceive it is safe for their children to play outside during the daytime. Okay, I'm going to ground us again in our next objective, because now you have a sense of what our health disparities look like in terms of place and weight in children. Now I want us to begin to associate those health outcomes with supportive elements of the vital conditions framework. Is this a thing you use? Can you be honest with me? Like, give me a head nod. Yes, this is. I'm getting nothing from the audience. Okay.
What was the question again?
Vital conditions framework, is this something you're familiar with?
I think I'd use it. It looks very similar. I wish Dr. Permachar was here. It looks very similar to the health system science context. So different wording, many of those headlines are very, yeah.
So the goal of this framework is really to move us away from terms like determinants, because as health practitioners, when we say things like social determinants of health, it can be perceived by folks that that means if you're exposed to this condition, you're gonna have blah, 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 blah. So vital conditions are things that really support one's ability to thrive. They're things like access to reliable transportation, things like access to affordable and healthy housing, things that enable people to thrive, sense of belonging in your community. And I love this because it helps us, I think, start from a standpoint of opportunity rather than one of disadvantage. And in community development, this framework has really changed the way we speak to each other in a way that invites folks to bring more resources to the table. So I like this. And if you haven't really worked within the vital conditions framework, I recommend just doing some research on this and grounding yourself in this. It's just from a conversational standpoint is great. And so just to remind you again, this health surveillance system I collect, I'm doing this with undergraduates only. And so every year when we collect this data, it's myself and a team of about 4 to 6 undergrads. And so we turn this into a really great learning experience. They're learning how to run the region's largest health surveillance system, the only one that is focused on children and their families, and one that we can mine down to the residential address. So there's a lot of learning opportunities for us here. And we really felt like the understanding this link between place, the neighborhood where you live, and health outcomes, is that a well-researched area of study? And so we started looking at, these are my students' posters, so they're really cartoony and sort of rudimentary, but I'm just going to give you snippets from each study that help us sort of align with what's taking place in the literature. In, I think this was 2015, Carilion's Community Health Needs Assessment, they did a statistical analysis to try to explore relationships between place, so neighborhoods, and adult obesity prevalence rates. And they actually did find that the odds of being obese as an adult were greater if you lived in 24012, 24013, and 24017. And so this gave my students a really cool model to go, hey, we do something similar with kids. Let's just replicate their data analysis on our data, and we'll try to look to see, does neighborhood matter? And sure enough, we found that if you live in 24012, 24013, or 24017, our children are also more likely to be overweight and obese. And so for us, this was like a really cool catalyst to figure out, in Roanoke, place really does matter. And that began to be part of a national conversation, which you guys now have probably heard of with, the influence of zip codes on being more influential than your genetic code and that kind of thing. But for us as physiologists, this sparked a really cool dialogue. We know that place matters in Roanoke, but what makes a neighborhood obesogenic? And so what I mean by that is, what are the elements of a neighborhood that increase the odds of being overweight or obese as a child or adult? So this let us go back to our surveys that we had collected citywide and really look at what are families telling us are the barriers to healthy living in their home neighborhoods. So again, we love doing this because it gives Roanoke City residents an opportunity to tell us these are the things that make it really hard to be physically active, to eat well, feel safe, to have a good community culture in our neighborhood. And the number one thing that we generally see in the city are infrastructure challenges. I'll talk about that again in more detail here in just a little bit. But other things like traffic and speeding, perceptions of safety, all of these things keep coming up over and over again year after year. And if we mine down to the neighborhood level to see, well, how is this different for someone who lives in 24013 versus someone who lives in 24017, and thematically, we see really different barriers to physical activity. In that neighborhood with the lowest life expectancy, we see things like drugs and crime and loose dogs. And in the neighborhood with the highest life expectancy in the city, we see things like too many hills, weather. Like, yes, good for you. But we also see things like traffic, and traffic pops up over the city. So when I give these presentations to cross-sector partners, what do you think they rally around? Hey, traffic is a problem for everybody. And maybe you've seen the traffic calming posters. Every year there's a new sort of strategy. Every corner is a crosswalk, for example, or no need to speed. You've seen those, I hope? It's because residents are telling us what the problems are. The cool thing is they're also telling us how to change those problems. So we invite families to tell us, based on the barriers you just identified, what would you do to change that issue in your home neighborhood? And so instead of just telling us infrastructure changes, they'll tell us exactly what they want, and then I can mine that down to the residential address level and see, in this neighborhood, people are telling us that they need more lighting. And in this neighborhood, they're telling us that their parks need to be updated. And it's completely open-ended and qualitative, so we get really specific information from these families. So for us then, I call like this vital conditions framework, it feels like an onion, and trying to understand how neighborhoods and places influence weight status in children, to me, feels like an onion. How do you pull back the layers? Because we can't infer cause and effect, but we can infer some associations. And so we go back to the literature with our students to try to understand who is looking at this in an adult model, because no one collects data like this on children at this level of scale. And sort of what are they doing and how can we replicate what they're doing in our research. And so in 2006, Jim Salas presented this socio-ecological framework of health behaviors that I just love. And if you're not familiar with Jim Salas's work, I highly recommend that you go look at it. But this socio-ecological lens really allowed people like me, physiologists, to be thinking about all of the sociological influences on health and how you might look at it from a built environmental perspective. And then in 2012, Brian Salins and Karen Glant, who you may know, she does a lot of work at the NIH, they started trying to document characteristics of obesogenic neighborhoods in adults. That's the same thing we're trying to do here. We know that place matters from the standpoint of health in children, but what is it about that neighborhood that makes someone more or less likely to be obese? So they were just looking at adults. We have since learned in 2013, Ann Carroll Scott started looking at perceptions of environments as a better reflection of what was taking place in a neighborhood than an objective measure of environment. Because what could we do? We could do a neighborhood audit, right? For every neighborhood in the city, I could do an audit and say, is there a grocery store? Are there parks? What is available? It was surmised here in 2013 that maybe perceptions of environments are better metrics than an audit, because it actually tells us what people are thinking about their home environment. Another challenge in unpeeling this onion too is we generally look at weight status as a static outcome. Weight trajectory might be the best way to look at how neighborhoods are influencing health. And so we've taken this concept of weight trajectory versus weight status at a time point to look at within a child. If a child is healthy at pre-K and then becomes obese in 3rd grade and we measure them again, is there something different in their neighborhood than a child who is healthy at pre-K and stays healthy? Or a child who was obese at pre-K and becomes a healthy weight by the time they're in 3rd grade. So we're starting to use this concept of weight trajectory, maybe to understand things better. And so we presented this work. This was a presentation we gave at the NIH State of the Science convening on food insecurity in neighborhood food environments, and we won the research award. My little undergrads did. It was amazing because we were able to document that perceptions of neighborhood environments truly did have a link with childhood obesity, such that children who perceive that they live in low access physical activity and food environments are more likely to be obese than children who live in neighborhoods that they perceive to have high access to both physical activity and healthy food. And so that was awesome, and we were really glad to see that NIH liked this. The other thing we found is these perceptions are really catalytic in a community. If you tell people with money that people are saying these things, they want to fund a strategy to overcome it. We also, because we're gathering perceptions, and again, I know that those slides are horrific, but they're just reminding me what to talk to you about. We can gather historic artifacts, like what happened during COVID based on how people were talking about resource access. And so we did a study that looked just at medically underserved areas to think about how perceptions changed during COVID. And we found that food access and physical activity needs, the needs that people were telling us, became much more proximal to the home. So people were saying, I need resources in my neighborhood right here, rather than, oh, I have access to this thing I can drive to. Everyone wanted to be able to walk to a resource. Stay-at-home orders, mandated that, right? It was cool to actually capture that in our city. They also really want neighborhood hubs of resources. So putting a bunch of resources together all in one place. How are we doing on time? We've got 30 minutes left. Okay, good. I was like, do I need to blow through this stuff? Fantastic.
You're good. You're the one talking.
Yeah, I know, but I'm going fast. And are you hanging out? You're with me? Okay. Let's see. We also gather information on nutrition behaviors and beliefs as a part of that survey. So this study also shows us that through the survey where we're asking families to describe what they do and what they believe, we can also see these natural artifacts and their influence. So what did COVID do to nutrition behaviors? We actually found that food consumption patterns in children and families and their values towards food did not change through COVID, but their shopping behaviors did, obviously. We actually found that more families are now shopping at farmers markets than ever before. So this also ties into that perspective of desiring proximal resources close to home and maybe the creation of neighborhood hubs. So it also demonstrated for folks who increased accessibility to SNAP and WIC, there was an increase in use in those food incentives programs. And so we can also demonstrate efficacy of programming through the data that we're collecting. So now to get us to objective 3, we've got a data set that can quantify our health disparities, that allows families to talk about perceptions of resources in their neighborhood, what they're using, their nutrition and physical activity behaviors. And we're able to document relationships between resource use, the types of things people want, and how that impacts childhood health status in the city. I'm going to make an argument now that each one of you can actually come up with answers to the challenges that we see when this data is collected. And I'll give you sort of my journey through this process that started in 2015. So in 2015, I was a newly minted associate professor, still imposter syndrome, trying to figure out, oh, what do I do? But I had this great data set and people seemed to like it. And so I started knocking on doors when I found out that the Robert Wood Johnson Foundation was trying to recruit a national cohort of cities who are going to use investment strategies to mitigate health disparities. I'm like, cool, in business investments, like investment strategies, they're going to generate capital as a way to reduce health disparities? I have no idea what that means, but that sounds fun. And the requirement of this cohort was to put together a team of 5 individuals in each city from sectors that traditionally did not communicate. And so the first door I knocked on was Chris Morrell's door, our former city manager, and got him on board. So City of Roanoke was like, yeah, this sounds great. And then I went to LEAP for Local Foods, our food systems experts, and then Freedom First Credit Union, and then United Way and Healthy Roanoke Valley. And so with Roanoke College as the anchor institution, we put together this team of cross-sector partners, and we're accepted into the national cohort for Invest Health. And for a 3-year, very intensive period with 49 other cities from across the country, we learned how to think about using investment strategies to mitigate health outcomes. And the goal was to really try to think about catalyzing transformative projects that would result in systems change. And for all of us, this was a really interesting way to think about how to approach a project. But I started to see action happening as a result of our data set. And so the Roanoke Valley Community Healthy Living Index was the reason we were invited into this cohort, but then we were all charged with coming up with strategies to try to mitigate our significant health disparities in the city. So we were learning how to leverage this data in really, really new ways. So if you look at the data first, what this figure is showing is family perceptions of access to park and rec facilities in their home neighborhood. So again, we ask families, do you perceive you have parks that are available for everyone of all ages to play? And we were super hyper-focused on Lansdowne at this time. The Lansdowne public housing development has the highest rates of childhood obesity in the city, and 100% of respondents told us they perceived that there were no parks or green spaces in proximity to Lansdowne. Horton Park is right across the street. It's literally, you can see it right out the window. So to say that you perceive it doesn't exist, man, this really got our wheels spinning and really helped us start thinking about those vital conditions. Why might it not exist to someone who lives right next to it? Well, they didn't perceive it was a safe place to go. And there was also nothing inviting there for the families. They're telling us the types of resources that they want, and they don't exist in Horton Park. It's just a big, big green space. So for the Kiwanis Club's centennial year, which was what, 2 years ago at this point, I think, they raised, I think, and this could be wrong, like $350,000 to put a playground in Horton Park. And now we can capture if perceptions have changed. Have your perceptions of access to parks and green space changed as a result of this piece of infrastructure? Gosh, I hope we see that when the data comes in from the 2024 Community Healthy Living Index. But this is an example of how perceptions of access guided infrastructure change. And it was a couple of unlikely partners, an exercise science and our undergrads, and the Kiwanis Club made this happen. Since that's happened, we continually have luck with infrastructure change. And so again, if we look at that map on perceptions of access to healthy living resources, here the lighter the color, the less access you have. In families, so in the Northeast community where we have higher populations of Latinx families, things like basketball courts and bike lanes are not desired. And when you ask families what would make your neighborhood more conducive to physical activity, they will say soccer. And so the soccer organizations and Parks and Rec came together around this data and got grants and talked Parks and Rec into converting tennis courts into futsal courts. So now those families have access to soccer in their neighborhoods. These things are used like crazy. That was a small investment that was transformative to this community, and again, I'm hoping we capture that change here pretty soon. So these small infrastructure changes were really nice wins for us through Invest Health to see if you can describe what people are telling us in a neighborhood environment, people with resources in other sectors will put resources in to build that infrastructure. And so how do we go bigger, right? The catalyst for all of this is citizens. And so, we want to start guiding systems change, right? If I want to create a system where a citizen has powers to make decision making, I need to invite citizens into those conversations on a regular basis. And so Chris Morrill, who was our former city manager at this time, had moved on to now become the CEO of the Government Finance Officers Association. And so he works with all of North America to help guide governments in how they use their budgets. So he invited me to do some work with them. The QR code will take you to that work if you're interested. We were able to position Roanoke as a national model for reforming government finance decision making, simply by positioning residents as the leads in those conversations. So have you heard of public deliberation and what that means? It's a model of citizen engagement where you actually recruit a cross-section of residents that look like and are demographically representative of your city. I'm going to change slides here if you've got that. You bring them all into a room, you pay them for their time, and so we also provided childcare and food. And then, I know the agenda is sort of ugly up here, but the goal is you teach those residents the tools that they need to make the same decisions that someone in that job could make. And so we convened residents to try to help us decide where our next HUD target zone would be. If you don't know what a HUD target zone is, in the city of Roanoke, the majority of all housing and urban development funds, the federal allotment that comes to the city, gets funneled into one target neighborhood for a 5-year period. And so the first HUD target neighborhood was in West End. And so the Freedom First Credit Union branch that has Leaps Markets there, that was one of the big projects that came from being a HUD target zone over there. And then they moved to the Melrose Orange target neighborhood. And so lots of streetscape improvements, and it's like this huge, massive focus of investment all in one neighborhood for a 5-year period. So it's like a $5 million decision. So we convened residents to decide what metrics should the city planning team use to identify which neighborhood gets to be a HUD target zone. Like, are they actually using the right metrics? And then the second task this group had was, after you make the metrics, can we test it and actually have residents decide where the next HUD target zone would be? And so we went through this process of learning and deliberating with them. We'd teach them something, we'd have experts come in who were neutral, we had residents come in to talk about the benefits and challenges of living in a HUD target neighborhood, and then they'd deliberate with each other. And then we'd show them more data and they'd deliberate with each other. And so what you're seeing here is neighborhoods that were on the table for becoming HUD target zones overlaid with my data. So that's the childhood overweight and obesity data. And so these were the types of things that they got to learn and deliberate about. Should childhood overweight or obesity be considered as a metric for making this decision? They looked at access to food, they looked at access to parks, they looked at perceptions of safety, they looked at life expectancy, and at the end of the day, we asked them what criteria should we use to select the next HUD target zone. And what was really cool is when we asked that question in the beginning, people were really honed in on focusing on opportunity and need as things that were weighted proportionally in that decision making. So, hey, we've got need and disparity, but also what's the investment opportunity? After the deliberation, all of those residents really hyper-focused on need over opportunity because they knew that the HUD funds would be the opportunity to funnel investment into that target neighborhood. So it was nice to see that this deliberative process actually worked with our residents, and we allowed them to make the next HUD target area decision. So we'll be moving, right now we're in Found Park. For the next 5 years, we'll be moving to Gainsborough. So that's a $5 million decision that the city allowed residents to make for them. So that changes policy, right? And it changes an entire system of investment strategy. After we had that big win, we started working with the city planning team on our comprehensive plan. And so again, it's an exercise physiologist, and in this case, my partner was from Freedom First Credit Union, so someone who works in a community development financial institution, working with our city planning team to reform our comprehensive plan. And why this is relevant is if we put something in the comprehensive plan, that means it becomes the city's priority for the next 20 years. And the minute it's in the comp plan, that means we can leverage the city's budget. So we've just taught residents how to make these big community government finance decision-making, right? We just taught them how to access our budget. And now we are putting priorities into the comp plan that ensure that that budget will be focused on each of the themes that you see here. We were able to get equity and health into our city's comprehensive plan for the first time in history as interwoven themes, and also livable built environments. I presented a lot of this data to the decision makers that helped get that in there so they could see our health disparities and they could see what families were saying about the environments that they lived in. But this means now when we are activating our city's budget, there has to be considerations for health and equity in it. Isn't that incredible? So for the next 20 years, we've got this amazing opportunity and resources that funnel into it. I'm getting close to the interactive time, I promise. So as a part of Invest Health, we had really one job. And so all of the progress metrics that I just presented to you, these were like small wins along the way. And for a comp plan to be considered a small win for an exercise scientist who works with undergrads was really cool. That was a cool moment for me. But we made the decision through Invest Health to focus on a neighborhood. And so we aligned all of our work with that national cohort initiative on the Northwest Roanoke community because Melrose Orange was the target neighborhood at that time. So that meant not only were they getting that $5 million infusion of investment, excuse me, when you're a HUD target neighborhood, that also brings all kinds of organizations and government partners and nonprofits together to build collective impact in that neighborhood. So we knew we wanted to align with that moment, and we knew we wanted to address challenges in Northwest Roanoke. And so we looked back at the community engagement studies that had been done in Melrose Orange over the course of the last 20 years. And when asked what is the greatest barrier to healthy living in your community over the last 20 years, the thing they would say over and over and over again was access to healthy food. And if you asked, well, how would you like that challenge to be overcome? The number one thing that was stated over and over and over again was access to a full service grocery store. And so our work in 2016 through Invest Health, first step was the largest community engagement study ever conducted in Northwest Roanoke. I think we knocked on 3,500 doors to better understand what that would look like. So if a grocery store were to come to this community, where are you currently buying your food? What's your purchasing power? How much are you spending every week? Are you using SNAP and WIC? How many people are in your family? What types of things do you buy? If you built a grocery store, could it be an independent? Do you want to see a co-op? Do you want a national chain? Where would you want it located? What elements should be in that grocery store? Could it be like a low service model like an Aldi? Or do you want something that is full service? They designed that entire model of what a grocery store could look like. And then my team spent the next 6 years in grocery pre-development to try to build a hub of resources for the Northwest community. And what we learned through that process, that 6-year process, that QR code explains sort of every element of this and using cross-sector strategies to get to that moment. We were not the only Invest Health team in the country in that 50 cohort team trying to figure this out. So in 2017, about 46% of all of the cities that were in that cohort were trying to address food access challenges in their communities. And the thing that we were all trying to do was grocery development. By 2018, only 2 cities remained on that journey because it was so challenging. And so it was Roanoke and Hartford, Connecticut were the only teams that had continued on that journey just a short 2 years later. And so just to show you what a stretch this is for someone like us who thinks in body systems and now is responsible for developing capital stack to bring a grocery store to life. When you look at why are grocery stores so challenging, this is a retail operation with a profit margin that's less than 2%. And the most expensive element is payroll. Well, if we're going to put a grocery store in a low-income, low-access neighborhood, you want to pay people a living wage, right? Because the goal is to create systems of support that enable people to thrive. And this is the neighborhood right next to Lansdowne. So the goal would be pay a livable wage so people can move out of public housing assistance and become independent on their own, right? Because we had been trained in sort of this cross-sector perspective, how do we leverage each other to make something happen? I viewed this as a massive opportunity. By the way, this also won an NIH research award because no one had yet been able to get behind the sort of paywall of national chain grocers to understand why grocery stores don't go into low-income, low-access neighborhoods. And once we found out that it was a workforce piece, guess who we called? Goodwill. Goodwill has retail experience. Goodwill's also in the workforce development space, which means they have really unique avenues to financial capital to support workforce. And so next Wednesday, the market on Melrose will be opening. If you'd like to come to the ribbon cutting, this is huge. It's been an 8-year journey for me. That started with health outcomes in children. It started with childhood obesity rates in Lansdowne. And then it perpetuated because we were looking at family perceptions of access to resources, and they were telling us what they didn't have. And then residents were telling us how to overcome that challenge. And then we put our collective strengths together to unpack why is it so challenging for the last literally 40 years. Why has a grocery store not come into this neighborhood? And slowly and meticulously as partners, we were able to lean on each other's strengths and resources to figure that out. So the market on Melrose is part of a resource hub. Let me go back to this picture. 1 second. We knew a grocery store could not operate in a silo. It needed other entities to support its finances. And when residents were prompted, by the way, they did this architectural rendering. This is what I did with through COVID with the residents of Northwest, is they actually planned the business model and the architectural renderings, and they brought this to City Council, and they were awarded $10 million in seed funding for being able to show this model with a real estate plan. But notice it has other elements to it. So we're going to ground the grocery store with other things. One, a preventive medical center with Carilion and Bradley Free and New Horizons as a partner. That phased opening, I think, is slated to begin in March of next year. There's also a CDFI, so not Freedom First Credit Union, Bank of Botetourt will be going in at Melrose Plaza to provide people with banking services and access to financial literacy. There is an adult high school in Melrose Plaza, so folks who did not graduate from high school and want an actual diploma and not a GED can finish high school there. We just had, Goodwill had legislation passed to make sure they get an actual high school diploma, and there's free childcare on site to support that. The Harrison Museum of African American History will also be moving into this plaza, so we are grounding these resources in a celebration of culture of the neighborhood. And then over the last couple of years, Carilion and the Department of Health and Goodwill have been working on a walkability institute that resulted in a whole bunch of streetscape projects that actually connected through sidewalks, Lansdowne to sidewalks where the playground is, and Melrose Plaza is directly adjacent to that. So now we have a hub of resources with a public library, a playground, and this grocery store and all of these other elements in walking distance to Lansdowne. Just because we leverage people to tell us what they needed and how to accomplish that goal. So I'm gonna begin to sort of end with why I think that you guys need to be doing this work. And the first thing, I've got 4 lessons for you. I've learned through this process that cities and bodies are fundamentally similar. That we are trained to think in systems, and we are trained to apply medicine or exercise to create cascades of events across systems. Communities work the same way. When we expose them to a stress, they adapt. Or in this case, if we expose people to the resources that they're asking for, we're gonna see changes. And so when I look at the data we've been collecting over time, we're able to capture changes in behaviors and beliefs that are occurring as a result of community development practices. And this sort of systems thinking mentality has really been necessary to bring these transformative hubs of resources to life. So you think that way, that means there's a space for you. The other big lesson that I've learned is data is a catalyst. And so I always like to frame myself with biological control systems because I'm a physiologist. So in the body, just like receptors receiving stimuli and sending information to the central nervous system, for the central nervous system to then recruit appropriate organ systems to cause action. Our data gets interpreted statistically by our team. We are the neutral hub, we're the central nervous system for this work. And then we recruit partners with specific expertise to do their jobs in collaboration. That is no different than how the body works. And so if you can start thinking about yourself as an effector in a biological control system, but at scale in the city, we can make really great things happen. The third thing, and again, if I'm framing this like a physiologist, is that system change requires collaboration across organs in a body and organizations in a city. Just like our body relies on integrated neuromotor, metabolic, cardiovascular, respiratory responses, cities function the exact same way. If we can lean into the vital conditions framework and really think about how people thrive, and we recruit those organizations to coalesce together and share their collective resources instead of competing for them, we can really make great work happen. And then, oh, I thought I fixed that typo. A second lesson, lesson 4. I've learned that collaboration really does require a neutral anchor. And so we've been fortunate at Roanoke College. We are not a threatening entity. And the Center for Community Health Innovation gathers funds from other partners and disperses them back out. And so in terms of a neutral anchor, this is something we've been able to do really, really nicely. Carilion serves as a great anchor in the institution, or in the city, for lots of reasons. And so just through your affiliation with this healthcare system, you're in a position to also serve a whole lot of organizations with Carilion as that backbone anchor. So I've just thrown a whole lot at you. And now the next thing that I want to do is actually invite you to think about points of intersection between your work and this community development work to try to figure out how we pull in more pediatricians, more physicians, more research physicians. How do we get the healthcare partners here as individuals more involved in this work? So I would just love to hear your thoughts. I've got some prompted questions here. Like, are you seeing health outcomes as different than what I'm seeing? And if so, how do we leverage partners to come together for this kind of work? That's all I have for you. If we can stop with a conversation or end with that conversation.
Anything coming in online?
How are you guys feeling? Okay, I hope? Question.
It's very common for me to hear from my patients when I encourage them to be more active, that they state those limitations. And it's as prevalent as it is other aspects of difficulty with accessing healthcare. And so I tell my youngsters that activity is good for their lungs, but they have challenges that with the schools schedules, with also the access to parks, and just being, as you said, being able to walk around the neighborhood and feel safe. So just getting in, regular ambulatory activities has been a very common complaint or observation that parents have when I encourage them to be active outside their schools. Schools as well, I'm understanding that having less time in some school systems for physical activity. And so encouraging the schools to be able to do that is important. There are also groups of children who live in more or less urban areas, more rural, and the ability to be active outdoors is also limited kind of in the other way. There are no sidewalks. There is, I go outside and there's, woods and such, and then there's not that sense of I can go, run down the street and hang out with my friends and such. So there's a mix of the population that I see that have challenges on kind of both ends as far as mobility, usability of their neighborhood environment.
Yep. So I actually love that you're saying these things. One of the questions we ask about neighborhood environments is the type of neighborhood folks live in. So they actually help to identify, is your neighborhood rural or urban or suburban? And so we can stratify the data by those things too, to see in these environments, what are the things people are asking for. Your comment about school schedules is super interesting to me, and so I made a note of that. That's one I hadn't heard. School schedules are sort of the bane of everybody's existence right now with bus schedules and things like that. But there are active efforts to bring walking and biking school buses to neighborhoods right now. And so we're trying to pilot that at a couple of schools where people actually, parents volunteer to create walking school buses for children so that there is a supervised opportunity for active commuting to school. Not the current superintendent, but the previous superintendent actually had policy making it, you couldn't actively commute to school. Like they were limiting that on purpose because they were so concerned about safety. So we're trying to figure out safe ways to address those policies. So I appreciate that perspective, for sure.
I've let others speak in, but you asked whether we're seeing some of this, these challenges and how we're feeling. So I'll say yes, is the answer on that. I think in the world of general pediatrics, unfortunately, we don't have any of them present in the room with us because we have some very, we have 4 general pediatric offices, and they have probably 12 different patient populations on there. That's kind of an exaggeration, but certainly there are some patterns, and there's some very big passions on trying to address those, and so I think those are interesting. I think the collaborative approach is powerful, and I'm not going to dominate. I'll shut up in a minute, but I want to talk to you offline because I think we've launched into the LIFT Center, which is a little bit of a collaboration, Freedom First.
That also was catalyzed by this data. Yeah.
Well, and I think it's a neat project. It's a small project. It may be an opportunity for us to kind of figure out how can we even collaborate further. But I think reinventing how we provide care, as a pediatrician, you come see me.
Yep.
Well, that's not going to work in these communities and with these patient populations. We have to reimagine. And a lot of what we learned at LIFT is sometimes there's the safety. That's great that we intended to come out here and help you, but do we have the relationship to let you get that close to us, in terms of the financial pieces and so many aspects. So anyway, very nice. I very much enjoyed the talk. Very thought-provoking, future thinking, future forward.
Yeah, thank you. LIFT is interesting. So one of the things I've recently learned too is there have not been good evaluative metrics put in to see how effective LIFT is. And so we just got another Robert Wood Johnson Foundation grant. I'm so thankful to them. They funded us 3 or 4 times at this point. In partnership with Reinvestment Fund, and that is a national CDFI that funds this kind of work. They were the program managers for Invest Health. But they're funding us to try to establish return on investment metrics for Melrose Plaza that aren't all financially focused. So how can we be really sort of imaginative about how we're measuring return on investment for projects like that? So we're using Melrose Plaza as the pilot site to hopefully create metrics also for LIFT so that we can capture, the challenge with absenteeism. Has that been eliminated as a result? That's the main reason why LIFT happened, was because dental problems are the #1 reason for absenteeism at Fallon Park. And so this was basically a unique kind of idea to try to increase graduation rates from that neighborhood strategy. Questions?
This obviously gets our community-based health side of our brain working really well and gives us a huge amount of food for thought, no pun intended for that. But whenever I try and boil it back down into how do I make this fit into a 15-minute visit with a patient, and how do I give them information that's both useful but not overwhelming for them, I sometimes have a problem with how exactly that gets applied. Do you have any data that looks at simply trying to give people information that changes that perception? As an example, you provided this example where we have a living situation, a community, and right across the street is a park, and they have this perception that it's not available. Does just giving them that information, here's a map of where your parks are and your access to that, do you feel like that has an immediate effect on patients' health?
I think in that instance, it would not have, because that was a concern of safety. So we actually changed the way police patrolled in that neighborhood. But to answer your other question, can you give information to people and see change? I don't know, but I would love to partner on this. So have you heard of the Exercise is Medicine Initiative? It's a partnership between the American College of Sports Medicine, my professional organization, and AMA, your professional organization. It is trying to help physicians prescribe exercise. So do you simply ask the question, hey, how physically active are you? How often do you exercise? Do you guys ask about exercise in your visits? If you do, you are incredibly innovative and on the cusp. Like, this is just something doctors don't do. But do you also ask about, talk to me about healthy food. Is it hard for you to get? Do you do that? Because there could be just some really easy, informational things that we could pass out to families that do the very thing that you are requesting. And if we had put, if we can put materials together by neighborhood, holy moly, that would be a great collaboration. I would love for our students to make those, and Exercise is Medicine already has templates for physicians to do that, so we could just adapt them to have a local flavor. Yeah, that's something you would actually give out. I would love to study that.
I think it becomes a huge challenge. We kind of have to, with a 15 or a 30-minute visit, it's unfortunate we kind of have to pick and choose what things we attack, and then
we need help. It can't fall on you, because that's not your chair is not going to be happy if you now make all your visits 30, 45 minutes. That he's going to be happy, but but what we also need is what are the resources to work on that, and can we get your folks to collaborate with our social workers to create those packets to help them? They may even have some. Are we duplicating work?
Yeah,
and what can we do?
There is research that shows that you are actually the most powerful. So people will listen to their doctors and they will not trust anybody else. So if the doctor can just plant a couple of seeds, the trust level that you have, I mean, there's been some really cool political research on this too, even like doctors talking about who they should go for, it lands with people. They trust doctors more than anybody. So you definitely are in a unique position to do something. But again, systems change, right? How do you change the system of how you guys operate to incorporate something like this in a way that is very easy and is a light lift? Like, we just need to think really